Greetings and welcome to, believe it or not, our 50th Town Hall series today. It's lovely to see all of you. I hope you're enjoying the spring, and I couldn't think of a more appropriate topic for the big number 50 than something that is at the true heart and soul of what Houston Methodist is about, and that's our faith basis and our spiritual care. And so we're here today to talk about our journey and to talk about our spiritual care programs at Houston Methodist. If you look at the top 20 hospitals in the United States by U.S. News and World Report, we're really the only one that today maintains such a strong tie to a faith tradition. There's several others sort of born that way, and we're very proud of that. We think that makes us very, very different and special, and we think it's a huge part of holistically looking at how we heal and care for our patients and their families and their loved ones. You know, going back to 1919, when Oscar Norsworthy sold his little hospital next to his home, he went to the people he trusted, the people at the Methodist Episcopal Church, and at that point we became a faith-based institution. They literally passed the hat, the collection plate, did bake sales to make that happen back at that time. We're delighted today to be joined by the Reverend Stacy Auld, who's our Senior Director of Spiritual Care and Values Integration at Houston Methodist. Many of you may have seen a very impactful announcement recently, which is that the amazing Charles Milliken, who's been with Houston Methodist for 20 years and has had a 6+ decades long career in ministry, is retiring in a few months, and I'm pleased to say that Stacy will become our new Vice President of Spiritual Care, succeeding Charles in that role. So congratulations, Stacy. We're glad to have her here, and thank you to Charles. We'll be doing many things to celebrate him over the next 3 months or so. We also are joined by Reverend James Adams, who is our Senior Chaplain over the Neal Cancer Center, and he will be talking about how that is impactful in caring for the patients that we see. If you have questions, as always, you can use the chat box, or you can text questions to the word DeBakey, or text the word DeBakey to 37607, and or use the chat box. And in the chat room, we have Jennifer Cobb, who's the Director of Spiritual Care and Values Integration at our HMH, the Medical Center campus here, and so she'll be able to answer your specific questions if you'd like. And otherwise, keep the questions coming in so we can have some great dialogue. So I'm going to turn to Stacy. Why don't you tell us about spiritual care at Houston Methodist?
Thank you, and thank you for inviting us to be here today. It's an honor to get to speak about spiritual care here at Houston Methodist. So I want to jump right in and start with a definition of spirituality. This is a definition that is written by Christina Polchowski, who is a physician, and she is an international leader and somebody who's trying to better integrate spirituality into healthcare. She's the founder and director of the George Washington Institute for Spirituality and Health. And so these are the words that she's written that help give some shape to what we're talking about when we talk about spirituality. So she says, spirituality is the way persons seek and experience ultimate meaning, purpose, and transcendent, and the significant or the sacred. It can encompass beliefs and practices within religious communities, but it goes beyond religion. Meaning, purpose, and transcendence can arise through vocation, family, or nature. So it's part of our human experience, and that's how we understand spirituality. So given that definition, what is spiritual care? Spiritual care is then this recognition and attention to spirituality within the healthcare setting. It relies on an interdisciplinary team and requires all of us on the healthcare team to be involved in this care. So including something like a spiritual history when a physician is maybe trying to learn the medical history of a patient, including some questions that ask about the spiritual history. Maybe some of our nurses or social workers also asking some questions to get at that, then helps to identify potentially some spiritual distress, some spiritual needs that then can be referred to a chaplain here in our hospital to help come alongside one of our patients and care for them spiritually while they're in the hospital. So when the chaplains come alongside and try to address or help identify these spiritual needs. Maybe they come up as spiritual questions or concerns. Maybe they're spiritual practices. They need somebody to come alongside of them and help them participate in some of their own rituals, such as taking communion or prayer or meditation. Those are the things that we do to care spiritually for patients here in our hospital. This next slide, I wanted to give you just a backdrop. A lot of y'all are probably familiar with the Kinder Institute here associated with Rice University. And this is their most recent data on religious affiliations in the Houston area. This was the data from just last year in 2024. And the reason that I bring this up and I highlight this is, one, I think this helps us understand the reality of people in our own Houston community, and it's our own community who is showing up as patients here in our hospital. So it's helpful, I think, to just name that, yes, there is a slow decline in people who are religiously affiliated with the Protestant church or the Catholic church. There's a slight rise, that 9% in people who are affiliated with other religious traditions such as Islam or Judaism, Sikhism, and several others that we find here because of how diverse Houston is. But then the most significant data point here is this rise in the nun category. And a lot of people would say, if you ask them today, they may not be officially affiliated with one of these religious traditions, but they may say they're spiritual but not religious. That's a lot of how these nuns kind of identify themselves. And these are a lot of the patients that we see in our hospitals. And so it's a rich environment, if you will, for people who may not be stepping foot into a house of worship here in the Houston community, but are finding themselves in a hospital setting. And chaplains coming alongside of them and offering spiritual care may be the most profound spiritual experience that they may have in that moment, because they aren't putting themselves in positions to maybe experience that as in a formal setting. But then they come here into the hospital, they start asking all sorts of questions. It's our human nature, I think, when we find ourselves laying in a hospital bed, to ask big questions about who am I, what is my purpose, maybe even asking the questions of who is God and where is God in this situation. And so our chaplains are there to provide care to all people of all faiths, and then of those who have no faith at all. We've been trained to be able to enter into those conversations and connect with people, especially those who really are not wanting to connect with us in a religious way. So this next slide just gives you a snapshot of just how we've grown in spiritual care here at Houston Methodist. I think Charles will say that 20 years ago when he started, there were 8 chaplains in our system. Now we have 70 chaplains that are serving throughout all 9 of our hospitals. We also have accredited training program called Clinical Pastoral Education. So we have residents and students. You see that number at 35. So we have a lot of people out on the front lines as board certified chaplains, as students who are training to be chaplains. And within that, we have a diverse chaplain staff. I love this picture of our Sugarland team because I think, one, it just illustrates the diversity that chaplain team has out there, and then also recognizes the professionalism that we carry into our work. This next slide gives you an overview in numbers to see what kind of an impact that the chaplain staff and our volunteers are making throughout our system. You can see that year over year, we've had quite an increase in the number of patients that we're caring for. You can see that too with our volunteer program. I'm going to speak about that in a little bit. Our patient consults, I think that's to see that number is increased, I think is testament to how our chaplains continue to embed in our clinical units. So the more known our chaplains are, the more that our nurses and social workers and physicians understand the role of the chaplain and the care that we can provide as part of the care team, they begin to make consults to us more often. Some consults come directly from the patients. They ask for us to see, but sometimes some other clinical team member has identified something and then has consulted us to maybe go in and make a visit with a patient. You also see that we have had a big increase in our advanced directives, and I'll talk about that. That's one of the services that the chaplains offer, is helping educate patients about their medical power of attorney, their directive to physicians, and then we help execute those for them. And then our staff support is something that is a big part of what our chaplains do. We saw a real rise of that in COVID, where our chaplains had always been caring for our staff, but this emphasis on really caring for the front lines became to a new level, to where I think our chaplains, if I were to put percentages on it, I think about half of their day could be spent caring for our staff in different ways, either on one-on-one support or in group support. And we believe that when our staff are being cared for, when they feel like that their spiritual lives are integrated into their work and that they're being attended to their own spiritual needs, then they are better equipped to care for our patients. And so staff care is an important part of what we do. This is the slide I want to lean into the most during this presentation, because I think this really helps put some words to what the role of spiritual care is in a patient's journey. Chaplains, I think, provide authentic presence and connection in an increasingly isolated world. I am working on a dissertation right now for my doctorate degree, and so I'm doing a lot of research on social isolation and loneliness and the impact that has, that those are both social determinants of health that we care about here in the hospital. And we know that when people are isolated and lonely, that can impact their physical well-being, their health. And so when chaplains are able to make authentic connections and visits and spend some time with people in the hospital, I think that's attending to some of that social determinant of health. They are having more connections, more meaningful connections through those visits with our chaplains. So that presence and then that intentional connection, I think, is an important part of what we're doing. Obviously, providing a good listening ear. We have a lot of training on what it means to listen well. And we know that listening well can be a lost art in our society these days. We just move so fast. And so to have a chaplain come in and actually practice listening well, to hold space for the stories that our patients have. We have so many stories inside each of us. We have our family stories. We have our faith stories. We have stories that give us meaning. And so when chaplains can help uncover some of those stories and listen to those stories, it provides value to the patient. And I've always thought, sometimes the medical story is what becomes the loudest when they are sick and they're in a hospital bed. And when that medical story seems to be the only thing anyone wants to talk about when somebody comes into the room, a chaplain comes in and is able to tap into and hopefully bring to the surface some of those other stories that have a lot of meaning that we need to recall as a patient. Facilitate meaning making. So trying to make sense of their situation, and we don't do that for them. We help them patients try to make meaning for themselves as to what's going on. And when we find that we can do that, it leads to greater acceptance of their situation, greater peace, both physically, spiritually, and emotionally. And then, as I mentioned before, bridging the gap in the multidisciplinary environment. As we become more specialized in all that we do from a medical perspective, there's a lot of players that are usually in the room or caring for a patient. And often the chaplain can be somebody that is able to help bridge some of those gaps and make sure that some of that communication is being understood by the patient with all the different people that are caring for them. And then educating them on their advanced directives, patients having documents in place where they know that they have somebody who can make decisions for them if they're unable to gives them a peace of mind and also helps support them on their medical journey. And then the last thing I put on there is something that I hope you think is obvious: attending to acute crises and end-of-life scenarios. You know, every time there's a code in the hospital, somebody's heart stops and the code team responds. A chaplain's part of that response team that goes to care for maybe a family member witnessing that, and then obviously any end-of-life scenario, our chaplains are always there to respond to the end of life here with our patients. I won't spend a lot of time on this slide, but it's up there so you can see kind of categorically. You could probably repeat a lot of the same things I said for patient care into how we care for our staff. But again, just reiterating, we have programmatic things in place. We have values integration initiatives in place. There's a lot of things in place that our chaplains are doing specifically to care for our staff so that they feel better prepared to care for our patients. Our volunteers, we could not do what we do and make the impact that we make without our spiritual care volunteers. And thanks to a recent gift from James and Carol Luke, we were able to establish a new system-wide volunteer training program so that we could provide the highest level of training to volunteers in our community that want to come and serve in the hospital setting. We have a little over 200 volunteers that are deployed throughout all of our hospitals. Right now, we train 3 new cohorts a year, led through our system-wide training program. And as you may have seen on that statistics stat, our volunteers alone made 5,600 visits in 2024. And I would guess that those 56,000 visits would not have been made up by the staff chaplains. Those would have just been touch points that weren't able to happen. And so without those volunteers, we would be missing a lot of the connections and touch points that we have right now. Last couple slides, I wanted to just highlight a few things from 2024 that we have been able to celebrate in spiritual care at Houston Methodist. One is that we dedicated our first chaplain to an outpatient clinic, which is the Neal Cancer Center, and you're going to hear from James here in a minute. But we know that when you look at Houston Methodist as a whole and you look at our patients that are a part of our Houston Methodist family, there's a huge percentage of our patients that hopefully will never come to the bed, never be inpatient, but will be receiving services from our outpatient services. And so to know that we seek to provide a spiritual environment of caring as part of our mission, we want our outpatients to experience that too. And so we're piloting this with James to see what it's like, to see what infrastructure looks like, to see what it will mean to be able to offer some spiritual care to people on their cancer journeys in this outpatient setting. We also launched our spiritual care research initiative. Last year, we hired our first spiritual care researcher dedicated to working with our chaplains to help develop them and what it might look like to start writing case studies and producing research out of Houston Methodist to partner with different physicians and researchers who may be working on something that relates to the heart or to the brain, but adding a spiritual care component to their research may help us see something and may fill out a bigger picture. We partnered with the Marc community, which is in the museum district, and it provides a therapeutic residential community that specializes in severe psychiatric disorders. And now we have a chaplain that goes every Friday to offer spiritual care to the residents in that community, and then they are there to support the staff too. And then that last one, we were awarded a $1.5 million gift from the Moody Memorial First United Methodist Church of Galveston in 2024, which is allowing us to establish our third clinical pastoral education site. And we'll establish that at Clear Lake, which will mean we can have more students learning in our environment to become chaplains after they complete clinical pastoral education. And then this last side, just looking ahead, one of our things that we're thinking about, we're obviously focused on for 2025 is celebrating that our Cypress location has opened back in March. And so we want to establish a strong spiritual care presence at Cypress. We have a director of spiritual care there. We have a chaplain, and we have our initial cohort of volunteers that have been trained, but we're looking to add more volunteers as that hospital continues to grow and see more patients. We also embedded a chaplain into the transplant center here back in January to focus on identifying places in a transplant patient's journey where they might have a need for spiritual care. So really assessing that journey that a transplant patient goes through and providing spiritual support to them along the way more systematically. That third one is thinking about part of that Moody money we had dedicated to expand support in our physician organization in the southern region, if you will, like around Clear Lake and Baytown and Sugar Land. And so we're looking strategically about what that might look like to add another chaplain to our physician organization that would be caring for our employees in those clinics. And then the last thing is that back in October, we had the Faith in Medicine Luncheon that we had about $400,000 given to us through that event that is dedicated to initiatives in oncology and spiritual care. So we are working with James, we're working with the leadership in the Neal Cancer Center to think about what new initiatives could impact our patients in oncology and spiritual care. So with that, I want to turn it over to James, who is our senior chaplain in the Neal Cancer Center and is going to share a little more detail about his work that he's been doing in the last year.
Great. Well, thank you, Stacy. I really appreciate it. Like I said, I'm James Adams. I'm the senior chaplain with the Neal Cancer Center in our physician organization. And what's unique about the role that I have is I work primarily in our outpatient setting here at our academic medical center campus, as well as supporting our clinics in the community through virtual care. And I'm just one of many folks in our cancer centers that are supporting our patients. Each of our hospitals has a cancer center located in it with our infusion centers, radiation, oncology. Our inpatient teams there support them very well. So we all work together as a team to support across our system. So today, though, I want to share a little bit about what I do in our setting, in the setting of outpatient care with my story working with Beth. And to be clear, Beth is a pseudonym. There's no privacy details are changed here to maintain her privacy. But this will give us a chance to sort of dig into what spiritual care looks like in our cancer center. So, Beth is a woman in her late 30s with a 2-year history of stage 4 breast cancer. She's married, she has a toddler, and I first met her in our infusion center during one of her chemotherapy appointments. And I met her because I had reviewed her medical records and looked at her age, her depression scores, her last oncology notes, her diagnosis, and how long she'd been in treatment, and recognized there may be some need for spiritual care and support. And so we met 13 times over 11 months, either in the clinic, through telehealth, or during an inpatient stay. And she's a vibrant, caring, and thoughtful person who spent a career caring for others and took meticulous care of her own body and health with diet and with exercise. Yet she received a devastating diagnosis after the birth of her first child. And she expressed spiritual pain, often asking, how can this be happening to me? And so Stacy gave us a lovely definition of spirituality when we opened up, and I want to share this one from the National Cancer Institute. And when we're talking about spiritual care, what we're talking about is that aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or the sacred. In essence, spirituality encompasses the way that we feel connected to what is most important to us. And when we lose and find our place in the world, but when we lose that sense of connectedness in one of these areas or all these areas, we can experience what we call spiritual pain and distress. And it's very hard to describe what spiritual pain is like, but it's often felt like an ache, a sadness, loss of meaning, hopelessness, feeling demoralized, that helpless feeling, or even sometimes physical pain. One image I use with a lot of patients that I work with is thinking of the human person as a combination of the body, the biological functions, our psychological makeup, our emotional kind of makeup, our spiritual beliefs and values, and our relational connections. And whenever one of these elements hurts, they hurt all the rest of them. And so when I think about Beth and her story, her spiritual pain presented as an inner ache of grief and loss of meaning. Her experience mirrors the statistic here, in which 78% of cancer patients experience spiritual and religious concerns. The difficulty in identifying who these patients are and getting them the support that they need. In a multi-site study of cancer patients measuring their perception of the quality of their cancer care, 52% felt that it would be appropriate to be asked by their providers about their spiritual and religious values or beliefs. 58% even said it'd be appropriate for a provider to ask them about their spiritual needs. Unfortunately, the study found that less than 10% of these folks had ever been asked by a provider or a clinic staff member about any of these topics. And so we're talking about Beth. She identified as Catholic. She had forged her own spirituality, though. She was not connected to a formal faith community or spiritual leader, and she held to a sense of karma that meant for her that the good she put out in the world would return to her. But in this case, her good was met with cancer and loss rather than hope for a future with her son and her husband. And her sense of place and purpose and meaning was shattered with this diagnosis. And her connection to a loving God and kind God was ruptured by mortality and loss. So she was hurting with no place to go process these big questions. And so I want to raise this survey here from the Chaplaincy Innovation Lab, which is a spiritual research and education organization. They conducted this with the cooperation of Brandeis University and the Gallup, because it may be assumed that most people can find support they need for their spiritual needs outside of the medical system. But in actuality, these folks, this study, the survey at least, found that 21% of Americans attend weekly services, and less than 30% of the folks surveyed feel they could have a trusting relationship with a spiritual or religious leader. And so, meaning that fewer and fewer people are frequently connected to a faith community or attending regularly enough to be integrated into that community, and even fewer folks feel they have an ability to, or actually a large number of folks do not feel they could have a trusting relationship with those leaders. So what this study also found was that 18% of Americans had interacted with a chaplain outside of a faith community, with more than half of those folks finding a chaplain within a healthcare setting. And among that group, 42% found the chaplain's work with them incredibly valuable on their spiritual well-being. And that 42% being very valuable, there was a Likert scale of valuable, very valuable. So a larger number than half found the chaplain's interaction valuable for them. And so I present all this to take all this data together. Spiritual care in the clinic is really an important piece of what we offer here at Houston Methodist, because patients feel that it's valuable, first of all. And secondly, because in our outpatient setting and among cancer patients, it's very likely that they'll experience spiritual pain and distress. And with Americans, they're less likely to be connected to traditional sources of spiritual support. And so when we go back to Beth's story, she was facing spiritual pain with her diagnosis, and she didn't have a supportive connection to a faith community or a faith leader. And like many people with this diagnosis, her clinical spiritual care was a primary source of spiritual support. And she reflects what we find among a large number of American populace that's not connected to the faith community or a spiritual leader. And this is important for us to consider because clinical spiritual care specializes in understanding the connection between spiritual pain and diagnoses. And so we consider how spiritual pain hurts. In Beth's spiritual pain, it waxed and waned over 11 months. There were times when her sense of spiritual pain was very acute, such as when her treatment stopped working or her physical symptoms increased. At these junctures, her experience reflected what our colleagues at MD Anderson found when they studied spiritual pain in advanced cancer, which is reflected in these numbers here. And what's important in this data is that most cancer patients experience spiritual pain at some level, with a much larger subset of those groups experiencing spiritual pain that they would describe as severe and chronic. And importantly, spiritual pain isn't isolated to folks with religious or spiritual identity. They also found in this research that 22% of the folks who did not identify with the religious or spiritual community still identified having spiritual needs and issues that needed to be addressed. So to kind of put the feet on the ground of what spiritual care looks like with Beth and what she and I were able to work together to do, I want to show you this diagram. This is from some researchers in the Netherlands, and it really helps take the lid off what spiritual care is. And so for Beth, spiritual care focused on supporting her values, tending to grief, exploring her beliefs, and reframing her spirituality to cope with her illness. And what this diagram illustrates is how I provided care in this case. So I screened Beth for spiritual pain through looking at her medical records and through a brief initial visit. Through more extended conversations and using a spiritual assessment tool for cancer patients, We were able to identify some primary and secondary areas of spiritual pain, and I used things like cognitive reframing, emotional validation, prayer, legacy projects, meditation, and homework to help relieve her pain at different points in her treatment journey. And then each time we met, we begin the process over again. So healing for Beth was a process of recognizing how her diagnosis had ruptured her sense of connection to her life's meaning, her relationships, and her spirituality. She was trying to make sense of what happened to her and how to live well under these circumstances. And she deeply valued her family and was grieving leaving them. So I supported her grief through expression and encouraged her ongoing connection to them by maintaining these positive relationships and spending time with her family. Her belief in karma was both a source of positive meaning and negative meaning. And so she wondered if she was being punished for wrongdoing, as well as recognizing how much good she had done in the world. So to intervene, we narrated her life story and reframed this belief by focusing on all the good she'd experienced by giving, as well as the good she had received from others throughout her life and through her cancer journey, as well as looking at her belief in God and what she had grown up in her Catholic tradition, what beliefs about God she carried with her, and what experiences of God we could rely on and come back to support her sense of peace and well-being. She was also grieving the loss of her career, the life that she hoped for, and the future of her son that she would not see. So I supported her grief in normalizing it, encouraging her emotional expression, but also helping her with legacy projects so that her memory of her could be passed down to her son in the way that she wanted it to be. We explored her sense of gratitude for the fullness of life that she had experienced. She also felt disconnected from God in the face of mortality and loss. So she felt that pain of unfairness of the circumstances and struggled to make sense of why, through karma or divine will, she was facing mortality at this age. So we found ways to connect to God and that were authentic, using psalms and prayers that could express grief and anger and hope. And on good days, I encouraged her positive outlook and activities that helped her feel normal and enjoy her life. In our last visit during her inpatient stay, she came into the hospital due to complications from this cancer. We discussed the end of her life and how she could decide what quality of life meant for her and make decisions about foregoing treatment and entering hospice care. And so for me, spiritual care embodies the presence of God to individuals in pain through a supportive presence using clinical skills that help enable someone to find their strengths within their souls, their life stories, their faith traditions, and their communities to cope with pain as well as forge new meaning in a meaningful life. In our visits, I tried to foster an environment of radical acceptance of whatever feelings and meanings that she was drawing from her experiences. And when someone feels disconnected from God or from their family or from themselves, radical acceptance allows for a person to feel connected again. Then we're able to work together to co-create some new ways of living in the world when life circumstances rupture our lives. And so over time, Beth was able to utilize these interventions to cope with difficult days, reconnect to her faith, feel a sense of meaning and accomplishment with her life, experience her grief, and voice her own legacy for her son. And because I worked within the outpatient context, we were able to work together over the course of her illness towards these ends. And like many spiritual care relationships, she left our hospital to enter hospice care and was then her care was then picked up by a hospice chaplain, and that's where she and I's story ends. And so at the end here, I wanted to share a little bit of looking forward to how we're leading spiritual care in this setting and what kind of looking outwards can look like in our cancer center and working with our cancer patients. And our outpatient care is a huge opportunity for spiritual care. When it comes to looking at our different centers, we have a number of people who come through every day in our clinics. Last year in the clinic here at our medical center campus, we had over 20,000 encounters in just the hematology and oncology clinic. That doesn't include the Peak Center for Brain Cancers and Tumors. It doesn't include our infusion centers or radiation oncology. That's just the amount of encounters seen by our physicians in those areas. I was able to have 700 encounters last year, so that's 0.03% of folks coming through our clinic were able to be touched in our outpatient setting, at least by a spiritual care visit. So if we think about all of our different centers throughout our system, there is a lot of opportunity of folks for care as they're coming through our outpatient areas. Virtual availability is a big thing. So one thing that I'm able to do is use our MyChart platform to provide virtual care for folks who are at home. So between their clinic visits, between their infusions, between treatments, they're able to reach out to me and ask for a visit. I'm able to reach back out through MyChart messaging, through telephone calls, through emails, and connect with these patients when they're at home, and then find times that are convenient and comfortable, or at least convenient for them, in a setting that's comfortable for them to have a deep and important conversation. One thing we're going on is research. So currently in our cancer center, our oncologists have a lot of energy around spiritual care research. We currently have one research study ongoing. We have another one possibly in process, and then the potential for a third one in partnership with another organization to do a multi-site study. So that's something that's forging ahead. Education is something we're working on too. So one thing that I help do among our physicians and our frontline staff is provide education on spiritual pain and distress, how to communicate well, how to use certain language to ask these questions and figure out who is it that needs care and who's struggling. And best practices. We're working on, like I mentioned before, we have a work group of oncology chaplains in our system who are working together to review research, to review best practices, to sort of align what we do with the research, and also working with partnership groups such as Transforming Chaplaincy and the Chaplaincy Innovation Lab to gain new insight from the research that's going on across the country and across the world in spiritual care to align our practices. I appreciate your time, and I'll turn it over to Dr. Boone for some questions.
Thank you, James. That was very powerful, and thank you for sharing the story and the journey with Beth. She was very lucky to have you in her life. Tell us about your journey of how you became a chaplain. I'd love to hear that. I'd like to hear that from both of you. Stacy, let me start with you.
Yeah, so briefly, I grew up United Methodist, went to college, and then I actually had a career before ministry. I was a jewelry buyer for Zales Jewelers. But through that experience of being a very engaged lay person in my local Methodist church, felt a call into full-time ministry. So went back to school at the age of 30 and got my Master's of Divinity out at Duke and came back. And I thought I was going to serve in the local church for most of my time working with youth, but wanted to have an experience by doing an internship in the hospital setting through clinical pastoral education. I thought it would make me a better youth pastor. Just getting that exposure. And I did that, and I realized this was the setting that I think God created me for. And so I moved to Houston in 2009 to do a residency here at Houston Methodist, and have been here ever since. So I've served as a resident, and then a staff chaplain, and then the director of the team here, and then the system director over the last couple of years. And so for me as a United Methodist clergy person, that this is where I feel like God's kind of given me, instead of a local church to care for and to think about the spiritual life of parishioners coming into a local church. I feel like God's placed me here in the hospital setting to help make that a reality for people, and to have a meaningful spiritual experience while they're in the hospital.
So let me pull a couple threads on your journey. So you mentioned the residency. So becoming a pastor, becoming a chaplain, not quite the same thing, right? So talk a little bit about how that generally
thank you for asking that question. Because we all at Houston Methodist, we only want to have board certified chaplains here on staff. We have a little bit of a lead-in time if you're hired and need some experience, but within 3 years we require that everyone's a board certified chaplain. So in addition to being endorsed by your faith tradition, which may look like an ordination, so for me it's ordination in the Methodist Church, endorsed by the United Methodist Church to be a chaplain, and then to have had my master's degree focused in theology, then to have a year-long, basically 4 units of this clinical pastoral education. And for every 1 unit, it's 300 clinical hours and 100 education hours. So I did that for a whole year here. So that was on top of any formal training I got in a seminary. It was that intense residency here in the hospital setting. And then I had to articulate and demonstrate 29 different competencies with our professional organization to be certified as a board certified chaplain. So in addition to, yes, the call that we have as pastors to lead, and for me as a United Methodist to express the gospel and to help lead people in that, my journey is that, plus learning how to be a good listener, learning how to be with people of all faith traditions and to express God's love and the example that Christ gave me to come alongside people who are hurting.
So that was one of the other threads I wanted to pull a little bit. So, I mean, if you had gone down the route you thought you were going, pretty much the people to whom you would minister would have been United Methodists,
right,
attending that United Methodist church wherever you were.
Right.
Here, you're tending to the spiritual needs of people from any and all, and sometimes no faith background. Talk about the uniqueness of that. Talk about how the training as a chaplain prepares you for that. Talk about our chaplaincy program here, because not everybody's a United Methodist like you. So talk about the profile of what is 70 plus chaplains and many other lay ministry and others like that.
So it was through my residency experience. Well, I had an internship at Children's Medical Center in Dallas that was a little bit of that's what gave me the taste of it. And so then I came here to do my year-long residency. And honestly, it was through that experience of meeting people at the bedside and recognizing that the human connection that we all have with each other. I think my heart grew. I think my mind expanded. I think my understanding of God became larger. When I think about just inclusion in general, I think about how, for me, my own theology informs my ministry, right? So even though I don't proselytize, I'm not trying to push my own Christianity on people, it is what has shaped me, right? So my understanding of Christ coming in the incarnation to come alongside of us, broken humanity who were sick and sad, and Christ came to be with us, which it's Holy Week this week, right? So we're thinking about how Christ came and sacrificed for us. That's what helps me understand why I'm doing what I'm doing at the bedside. But I see the humanity in all people, and if somebody has different religious traditions, for me the most important thing is that compassion that Christ showed, to be able to come alongside and say, how can I support you in your own beliefs and your own things that give you meaning, that may give you strength to get through this. And so that I feel like me offering that compassion is what I have been called by God to do. And our chaplain team has gotten more diverse. We are primarily different denominations within the Christian tradition, but we do have Muslim chaplains on staff. We are always looking for, trying to recruit into our CPE program people of different faith traditions. And that's just kind of why people are not doing it, kind of as dependent on their own faith communities. But even with our lay ministry or our spiritual care volunteer program, we have had a group of Hindus and a group of Muslims and a group of Jewish lay people in our community that have come to us and said, we'd like to, learn, we'd like to be trained to be able to go into the hospital setting and help care for people. And so we're seeing it expand so that we can care for a diverse. And then the last thing I would say about that is that's why it's so important for us to have good relationships and partnerships with faith leaders in our community. Because I may not be the best person to care for somebody, depending on what their spiritual pain and is their spiritual need. But if I can help connect them to a spiritual leader, an imam or a rabbi that can come in and do that, then I feel like that's part of our role too as chaplains.
Perfect. Well, thank you. Thank you. James, tell me your journey. I'd really love to hear.
My journey is sort of circuitous and unexpected. I didn't know you were a jewelry buyer. I actually sold men's clothes out of college.
Wow. Okay. You're both salespeople. Okay.
Yeah. Well, it pays off sometimes. I actually got into this incidentally. So I was I went into college thinking that some ministry thing would be in my future of some kind. So as I got into college and started studying, I really loved history, and so I went to seminary. Primarily orienting towards religious history. Was planning to do a career in academia, was what I was shooting for. Ended up doing a second master's degree from Catholic University of America in their religious history program. And then after a number of failed PhD applications during the academic downturn of 2015, 14, 16, those years, I sort of gave it up. And so at the time, my wife and I and our kids were living in North Carolina around Durham, and we were attending a parish there near Duke University, and so one of the divinity school students came into the parish one morning after working all night at UNC Chapel Hill's medical center and said they're short on their training program for the fall. If you need something to do, it might be worthwhile. And I was unemployed, couldn't get a job, and they paid $1,500 stipend for 11 weeks of training. So like, sign me up, and I did. And in my training, I didn't do a lot of practical ministry related things. I didn't do any counseling training. I was doing the academics and the histories. So I showed up cold turkey to a level 1 trauma center with a burn center and a psychiatric hospital and a pediatrics wing, and went by the seat of the pants and sat down at bedside with folks. And one of the first major interactions that I remember was a lady who had both legs amputated, had kidney disease and some severe diabetes, some other things, and was down that day. And she wanted to go and tell her children that she was done with medical care. She just wanted to go home and be with them and let nature take its course and let the disease process do what it's going to do and let God have his way with her and go home. We had a very long, extended conversation. Out of that moment, I knew that this was the place that I belonged for some reason. So I did a residency year in pediatrics at UNC Chapel Hill, and then did a second year of residency in palliative care, and did board certification after that. And I've supported folks in home hospice care, as well as long-term care for a short stint. I worked in went back to palliative care and bereavement coordination, and then my wife and I moved to Houston to be both at Houston Methodist. She's one of our magnet program coordinators, and ended up with the liver transplant group here, and then through a number of opportunities with Dr. Chang and the Neal Center, ended up in outpatient cancer care. And so that's kind of the circuitous route that I took. Like, it wasn't planned. It was something I fell into, and it was the right thing at the right time.
Yeah, it sounds like God was planning it. But
that's how I look at it.
You know, I couldn't help be struck even hearing your story now, but the story before. And I mean, you all tend to so many people in crisis, so many people in pain. How do you care for each other? How do you tend to the needs of your chaplains? And from that, I want to talk about our employees and others. But you got a tough job.
Sometimes. We tell this tough stories. The beauty of outpatient care is that there are fewer crises in the outpatient side than there are on the inpatient side, which is nice. I've got to meet with some folks who actually have improved and done well. They've rang the bell and completed treatment. Some folks that I work with are actually in survivorship, and we're just working on adapting to what is life now that I'm here on this side of things, which is wonderful. When it comes to caring for each other, among the oncology chaplains, we do meet every other month for debriefing with one another. We are available for each other to talk through hard cases. We have colleagues across the country that we can speak from. I've worked in a few different places and settings and know folks kind of all over, so I'm able to reach out to them. We have in our team on the corporate spiritual care side, we meet every Monday for a huddle to kind of check in with each other in monthly staff meetings. Those are sort of the main inbuilt programming things that we have for the chaplains, at least from where I'm at anyways.
Thank you. And one of the questions that came in over the wires was, are our programs limited to patients, or are they also open to family members, visitors, others who are in
Absolutely.
the hospital setting?
Yes, our chaplains are caring for the families too. We often say that patient, families, and staff is kind of who we care for. Because sometimes you can walk in, part of our training, we learn this term kind of to the identified patient. I could walk into a room thinking that the patient laying in the bed is who I'm there to care for, but it turns out that in that moment, it's the wife of the patient that's sitting in the room that needs more care in that moment based off the circumstances. So it is being aware, it's being curious, it's figuring out the family systems, the family dynamics, who are the players, and then offering care to everyone that's a part of the system for the patient in that moment.
And similarly, we have chaplains who focus specifically on our employees, correct?
Yes, thank you for asking me about that, because that's something within the last 5 to 7 years we've started to build up here that I think sets us apart from a lot of hospital systems. One, our chaplains that are inpatient, they are also caring for the inpatient staff because they're embedded, so they're seeing the patients, but they're also rounding on the unit. They're doing things with the clinical staff that are inpatient. But here at Houston Methodist, we have the physician organization that has 250 plus clinics all over Houston with employees working in these clinics. And we have a corporate employee base that are all of our IT folks, our marketing folks, our HR folks that are not in a clinical space. So they're never getting exposure to a hospital chaplain. And then in our research institute and academic institute, again, people in laboratories, in the research labs, throughout that research institute. So now we have we have 3 chaplains. Each one is dedicated to one of those areas. So we have a physician organization chaplain, a corporate employee chaplain, and an AI RI chaplain that their role is 100% employee facing. So anything that we are the inpatient chaplains are trying to do with the inpatient staff. They are finding creative ways and programmatic ways and one-on-one consultation to be able to care for our employees that may never encounter a chaplain because they're not in a clinical space. So.
Well, I'm going to wrap up. I'd love to hear about the future a little bit. Any innovations you see coming down the pike over the next few years that you really want to focus on? Let me start with James. I'll come to Stacy to close. So.
Yeah, I think, like I mentioned before, I think the outpatient setting is going to be one of the biggest things that we can do here in our setting. We, as the PO, the physician organization keeps expanding and putting more clinics throughout Houston, there are more opportunities to reach out to our patients in our primary care and our specialty care clinics. Particularly in our cancer centers, we have a large number of folks that are just continuing to grow year over year that are coming to see us for cancer care, and so finding ways to connect with them both virtually and in person and across our system is going to be a big step forward for us, as well as research and best practices. These are kind of the three major areas that we're looking at.
Mm-hmm. And I think some of what the modality of delivering spiritual care, I think, is what we were kind of forced to do it in COVID, right? We were forced to learn how to offer care over the telephone or over an iPad, and we realized, you can actually have a meaningful connection. We don't ever want that to replace a face-to-face human connection, but what are some of the ways, and even at our Cypress Hospital, being a smart hospital, what are some ways that we could potentially pilot what it would look like, if that hospital isn't staffed with a chaplain 24/7 right now, and it probably won't be for many, many years, that most of our hospitals aren't. There's chaplains on call, but what would it be like for the chaplain to just like the inpatient, the nurse is doing, coming on your screen in your room to do your intake and ask you all those questions, that we could virtually kind of buzz in a chaplain to be able to care for somebody at 11 o'clock at night versus saying, I'm sorry, we don't have somebody here in the hospital right now. We can come in, when they get here tomorrow. But having some of that more virtual real-time access to chaplains to enhance and supplement what we already have, I think, so using technology, I think, is a big way. Even capitalizing on the MyChart messaging. I mean, I'm in, several group texts with different groups of friends where we are offering care to each other just through our phone. And so, you think about just a meaningful exchange through your MyChart messaging. I mean, who would have thought that's how we would have been trying to offer some care? But James is finding that meaningful. Check-in that's all they needed, right? So.
Well, that's great. Well, I want to thank both of you for amazing work that you do and for the people you lead and the people you care for. You make a real difference, and you differentiate what we're able to do at Houston Methodist in caring for our community. So thank you both.
Yes, thank you.
I really appreciate it. Well, I'm going to give you a quick update on some goings on at Houston Methodist outside of this realm. We actually heard the name Dr. Jenny Chang just a second ago. Dr. Chang was the head of the Neal Cancer Center, and when Dr. Dirk Sussman, who you all know well from these town hall series, retired last year after national search, I had mentioned before that we announced that Dr. Chang would take that position, and she's off to a wonderful start now, about 90-ish days in as the head of our academic institute. Many of you may have attended our Faith in Medicine luncheon in September, October. Dr. Chang actually gave an incredibly powerful testimonial about her faith journey and really how she sees faith involved in caring for cancer patients in her specific situation. So I know she has a very intense interest in the research side of that and working with you along the way. We've also mentioned Cypress. Here's some photos of Cypress. Cypress has now been open for 4 weeks and 1 day. I just looked at the 4-week data this morning. It is off to an absolute flying start so far. It really is quite remarkable how fast this is growing for us. We had ambulances lined up at 7:30 in the morning. That morning we opened up. I mean, literally as the doors were opening up. You actually see a photo there as well of the first baby born, a little boy named Tatum. So he is wearing, you can kind of just make it out, a new in town onesie. It was a limited edition, first 50 babies only born at Houston Methodist Cypress. And you can see some of the fun events we've done with our teams. the command center on the right. I mean, opening up a hospital like that and working out, obviously making sure everything is safe and effective, but also dealing with kind of a lot of issues, operational things on the fly. Has a whole command center and really, hundreds and hundreds of people. You can actually see almost 700 people that are employed already. We saw 160 emergency department visits in our first week alone. We're now seeing about 48 a day already. We have 54 patients in medical surgical beds, plus patients in ICU beds, plus patients in labor delivery beds. So we're actually already talking about how quickly are we going to start building out some of the additional space. And so we've been embraced by that community. We embrace that community and are very excited to see it. And one of the things we are doing there is really innovating tremendously. We have built this as an innovation hub for our system, fully recognizing that while we can build this to be ready for all technology and everything else, we have to then figure out how do you put this in legacy physical infrastructure around the system that varies in age from a couple years old all the way up to 70 years old in some cases. They are piloting a very interesting new nursing care model, what we call a 3I integrated model, and it's innovation, integration, interaction. So innovating and using artificial intelligence, for instance, having digital whiteboards, having voice activation in your room, having AI-powered fall prediction and prevention and other things along those lines. Integration across this, where we are taking a bedside nurse and a virtual nurse and figuring out how to create a team-based approach to nursing. We have pioneered virtual nursing. It has been phenomenally successful with our patients who love it, our nurses who love it. I'd put us at the top, fraction of a percent nationally in figuring that out. At all of our hospitals leading up to Cypress, where that was very much focused on admission and discharge work and has been very successful. We're looking at an even kind of next level model there, and if it works, we will figure out how we move that across the system. So very excited about that. And then really interaction. Like all of our technology, one of the massive goals is to free up our human beings. We just saw great examples of that, and use technology really to amplify their ability to interact meaningfully with the people we serve, and taking them away from technology that actually pulls them away, but creating those situations that bring them closer. And very excited to see that and pilot that and move very quickly with that. As a result of all of this work, actually, Gail Vizella, who is our Senior Vice President and Chief Nursing Executive across our system, was one of the key people interviewed in a national article by Becker's around how we are focused on nursing in a virtual manner, and how that can amplify and improve the patient experience and also improve the nursing experience. It enables us to tap into a nurse who may only be able to work 4 hours a day, for instance, because they've just had a kid or they want to get their kids to school, or a nurse who's perhaps got some mobility issues and says, I can't quite make it around a lot of big nursing units, but I sure could sit at a computer for a few hours and interact meaningfully with patients. And so it's bringing nurses back into the workforce as well. And so winning on many, many fronts. We've also been busy around the system. We're piloting an ambulatory surgery center in Bel Air. It's on Bissonnette, just inside the loop, starting with ENT, orthopedics, hand, and ophthalmology, ramping it up slowly as we're testing out this concept. Like everything else we test out, if this works, we will move quickly around the system. We're also, as we've talked about before, building comprehensive care centers as we've gained such critical mass in clinical care, around physician care in particular in the community. It gives us the ability to aggregate physicians together in a location, really create even more of a team experience and a facilitated and seamless experience for our patients, and frankly fill in what I call the interstitial spaces, some of the gaps in town that, between where we would put a very large hospital. So this is an example, for instance, in Cinco Ranch, which is about a 65,000 square foot facility. You can see the steel going up. These things actually are fairly quick construction, so we will have this turned over to us in November from the construction and operationalized by January or so. And so very excited to see that, and you'll see many more of those to come. I always talk about focus on the fundamentals. The awards will come. I'll show you a couple. Newsweek had us as best hospital in state. You can see how they ranked our network hospitals as well, very highly in the state. We had Newsweek also looking at the world and looking at the best specialized hospitals, and our Houston Methodist Hospital and the Med Center was featured very prominently within that group as well. This is one I think is really neat, given our focus on innovation that we've been talking about. Fortune magazine put out a list of the most innovative companies, not hospital systems, companies in the United States. So, I mean, at the top of this is like Meta and, NVIDIA and Apple and institutions like that. We're number 35 on about a 300 institution list, with pretty much everybody above us being somebody like that. We are the number one ranked health system in the country on that list. Kind of right a little bit behind us, the Mayo Clinic, Mass General Brigham, the Cleveland Clinic, and Duke. So, I mean, you're talking about some really tremendous institutions at the top of the list there. And this is another one I'm very proud of, because you heard it as we ministered to our own employees. To care for the population, for the community, to serve people, it takes amazing people who come to work filled with passion and purpose with what they do. So we work tremendously, and y'all are an example of that, to make this a great work environment. Forbes put out the best large employers, not the best health systems, but the best large employers in the country. We were number 3 on that entire list. Through anonymous surveys, we don't even see or know exactly how they do that. By far the highest ranked health system. Glassdoor, which is sort of a job ranking and job recruiting kind of site, put us at number 18, which was far and away the number 1 health system on their list. So very consistent external data coming there for us. One of the things I'm very proud about also, and I just wanted to feature, each year through our community benefits program, we support a lot of community activities and a lot of charities and community health centers, federally qualified health centers, etc. We just dispersed about $10 million in direct grant investments to these partners. Over the course of this program, over 83 charities that we have supported at $185 million in support. So very, very proud of this. And that's just one portion of really what we consider the charitable care and connection to the community that we provide. In direct charity care at cost, we're in between $400 and $500 million a year, as well as then many other community benefits like education and academics and research and other things like that, totaling well over about $1.3 billion in a way that the state mandates that we all measure that. So we're very proud of that impact we have in the community. As we focus on our employees, part of that is focusing on our faith, and part of it is focusing on our values. And actually our Spiritual Care and Values Integration Department, hence the name Values Integration, focuses on an I Care Recharge Week every year, and our employees get together and do fun things and create poster boards and different contests and other things to really reflect upon and reinforce those values, and it's always a fun and exciting experience. And then I'll finish up with, I hope you've been seeing some of our new advertising. We really have been connecting the message that, we are there to personalize the care for you. You see, that's the difference between practicing medicine and leading it, which has been something, people come up to me and just can rattle off. And what you're hearing is just a small little addition to that at times, just to remind people that, hey, sometimes it seems a little esoteric to be talking about, somebody with stage 4 cancer of the breast, or somebody who needs a liver transplant. But the reality is, unfortunately, that those things can happen to any of us, and we're there for you for your primary care, for your orthopedic care, for your specialty care, whatever that is. And so you'll hear that little tweak as you listen to some of those ads, which is that's the difference between practicing medicine and leading it for you. And I think it's tested very well. You'll see the billboards as you see an example here. And we're trying to connect more people to the great care at Houston Methodist. So with that, I'll wrap things up. Our next session is actually in September. We'll take the summer off. We're about on a quarterly basis now. So we'll see everybody, I believe it's September 10th. And wish you lots of health and wellness. And thank you very much for attending today.